present on this Grand Rounds webinar. It's a simple, probably straightforward case. It's a 62-year-old male with complaints of pain radiating down the left thigh and calf for the past 4 weeks, associated with weakness and numbness in the left foot and ankle for the same duration. His pain aggravated on standing or walking few steps, and the VAS was 4 for back pain, 6 to 8 for leg pain while walking. The symptoms were relieved on lying down. He had history of chronic back pain for many years, but he was not. He was able to do all his routine activities. He had no other comorbidities, and even though he was on medication and rest for the last 4 weeks, his symptoms were not getting better. And on examination, he had a left-sided foot drop with high stepping gait, and there was restriction of lumbar spine movements, more so in extension. The straight leg raising was not very significantly positive. His left ankle dorsiflexion was weak, 2/5, along with EHL and ETL weakness. And there was a sensory blunting of left side L4 and L5 dermatomes. The other power was normal in the other limb and the other muscle groups. The left ankle jerk was also absent. The distal pulses were normal. This was his standing X-ray. It showed a little bit of a list to the right side. The lumbar, the sagittal profile seemed to be all right. And this is the MRI. It seemed to have that, it looks like probably a primary stenosis of the canal with a disc, central disc at L3-4 and L4-5, with new extrusion at L4-5, which was migrating downwards behind the L5 body on the left side. So this is another sequence. Central and lateral recess stenosis at L3-4, as well as at L4-5 with an extruded disc at L4-5 on the left side. And he also had a small node at L3-4, probably contributing to his back pain as well. These are the representative axial cuts. So should I wait for the discussion now? Or?
Yeah, I think you can take the opinion of the house, you know.
Yes, sir.
Yeah. Let's start with our panelists now. Zubair?
Yeah.
Lead off.
Well, so looks like we're dealing with a middle-aged patient with unilateral foot drop, L4-5. Probably, by straightforward, perhaps I would obviously rule out all other comorbidities, diabetes, especially in this individual. There are no comorbidities, right? Because diabetic foot drops are difficult to recover. I'll definitely make sure that the patient is aware about the foot drop. Are there any flexion extension films? Because I didn't see flexion extension films. Look like quite stable.
Yeah, there's only a standing X-ray. No, we routinely don't do.
Okay, so fine. So as long as there is no listhesis, perhaps this patient would be amenable to a single level L4-5 MIS decompression and discectomy using the standard tubular approach, which I am quite used to. And that would perhaps take care of his stenosis as well as his disc issue. And there would be an associated over-the-top decompression as well at a single level. Okay. That would be my option.
Thanks. Dr. Dubey?
Yeah, it's a short history. There is the curvature most probably due to spasm. 1 month history, more leg pain. It's a discectomy, whichever way you want to do. But don't do it open. That's what I would.
Okay. Ketan, endoscopy point of view.
Yes, sir. There seems to be central stenosis at L3-4 and L4-5 is the acute disc herniation. So I would prefer to, it can be done both ways. We can do a 2-level transforaminal surgery using a more steeper approach for L3-4 level to take care of the central parts, and angular cranial to caudal angulation approach for L4-5 down migrated disc. But nowadays I would prefer to do this by a biportal approach, a 2-level UBE procedure, wherein if you look at the L3-4 level, even though the patient is predominantly left-sided symptomatic, he also has a right-sided L3-4 lateral recess stenosis. So an over-the-top decompression of that level also I would consider in this case.
Nikhil, would you think we want to instrument, do a T-lift also along with this?
No, actually, he has a very short course of symptoms, and his main symptoms right now complaints are left-sided foot drop with weakness. So I would just address that right now, being a middle-aged, and considering the fact that his L5 disc is not so healthy, and there is a lot of facetal fusions at both all the levels. If you stabilize at one level fusion or 2 levels, the adjacent segment going into problem will end up very quickly. So I would just do a tubular decompression at 3, 4, and 4, 5. Only thing is, it's a very small developmental kind of stenosis. The interpedicular distance is very small. So I would have to go with a very smaller tube, maybe a 16, and do an over the top so that I can get a good phlebum resection, and then do a discectomy at 4, 5. Just see the 3, 4 disc. If it's bulging, then do a discectomy also at 3, 4, or only a decompression.
3, 4 only a decompression.
I think so, because I'm not sure whether that disc is completely bulging. But if it is, then I would do a discectomy. But otherwise, 3, 4 decompression over the top, 4, 5 decompression with a discectomy.
Okay. Arvind, your last comments?
Yeah, I mean, I would agree with most of the comments here. The only thing is, counseling is also very important in this patient. You have to tell them that his back pain will probably never get better because he has a very degenerated back, with extensive degenerative changes. What we'll be focusing is on, trying to improve his foot drop as well as take care of his leg symptoms alone.
Oh.
Can I add to it, Dr.
Please,
Kaida?
Samit, please.
Why everyone is after L3-4? Patient is having a chronic low back pain and the acute onset of foot drop on left side, which corresponds to L4-5. Why you want to consider an L3-4? Just do only L4-5 decompression and just get it out. Why you want to complicate a simple issue? That's my comment.
Fair enough. Very fair.
Stenotic on the lateral recess on the left side.
He's got a bilateral lateral recess stenosis at 3, 4.
Yeah.
For any chronic low back pain with a decreased disc space, you are going to see this very commonly. And the patient is having Crohn's. So you don't treat an MRI. Patient has come with a leg pain. That's what my contention.
Yep, fair enough. Phani, can we go on with what was done?
Sir, yeah. So on discussion, the component of his back pain was significant. So, and he had, what I thought is there is significant decompression at both the levels L3-4 as well as L4-5. So when he has ankle dorsiflexion weakness, it is more like an L4 nerve root affected as well as L5. So there could be a compression at both the levels contributing to the problem. So I had opted for a fusion at both the levels with minimally invasive approach with TLIF at the L4-5 level with screws inserted on the right side first with the held in distraction, and then tubular retractors assisted TLIF at L4-5 followed by decompression at L3-4 with discectomy and over the top decompression, and then completion of the fusion fixation.
Okay.
This is what I had done, sir. And this is now it is 1 year, and his back pain was better after the surgery, and leg pain was completely resolved. Now after 1 year, his ankle power is 4/5. He's able to walk almost normally.
So why would you want to extend your instrumentation to 3, 4? A lot of people have felt that we could just do a decompression at that level. What was your rationale in that?
Two reasons. One is that there was significant decompression at L3-4 as well, with very narrow canal. There, the facet joints were too close. So the decompression process might actually aggravate a problem there, maybe leading to an instability. That was my main worry. With a central disc, decompression alone probably could lead to some neurological problems. So I wanted to be more safe. And there is a small node there which probably might be contributing to the back pain significantly. That is the only acute, area which we see on the stir images. So that's the reason I considered to fuse both the levels. Okay. He's 62 years old with not much of demand. He's a retired worker in Oil India.
So why not a interbody cage at L34 as well?
Correct.
Yeah, the L34 usually the mobility at L34 is much lesser than the other L45 and L5S1, and I just wanted to also reduce the duration of surgery.
Okay.
So I just did a posterior fusion there, facet joint.
Subir, your comments?
Yeah, what I would like to reiterate is that when you can get away with a simple decompression surgery, adding a fusion for the purpose of helping back pain is a philosophy that I do not align with. Although that was what was taught to us during our training years and fellowship, I over time have realized that despite whatever amount of fusion you do, the back pain still persists. So if it is like 80% back pain coming down to 60% or 60% coming down to 40%, the patient is still going to crib that there is a little bit of back pain going on. So the only way I think you can find a semblance in these cases is that what would you do if you had, this is your MRI, you are sitting in front of a spine surgeon and you want him to do a surgery. That is a philosophical question that I would ask myself before embarking upon a two-level fusion in such a case where there is no documented instability.
Okay.
Karthik, more than the case, I am fascinated by these horizontal incisions. How many of you take these horizontal incisions for the tube and, the healing issues? Is there any cosmetic appeal in these? Or Phani?
Phani, your comments?
So this is, whatever few cases I have done, most of them, if it is single level or most of them are horizontal incisions, and they do heal much better than with vertical incisions. Right now, I don't have the pictures of the, but I not had any problems of wound healing or bad scar. Actually, they look better than the vertical incision.
Can I comment on this?
Please, please.
Yeah, so in 2007, I had been to Korea for this MIS relief, and there was Dr. Park who was doing at least 4 or 5 surgeries per day of MIS relief in 2007. And he used to do always this transverse incisions rather than these vertical ones. And his contention was that these scar is much better because they are along the line of Langen's line. And whenever the patient does an extension or anything, that crease, it goes up to the crease of the back. So he was always doing this transverse incisions. And in initial my practice, I also started with these transverse incisions. But then I was much comfortable with the horizontal ones, the vertical ones. Yeah. But they are very good for cosmesis. That's what I would say.
What if you have to readjust the position or you're a little off target? Then how would you?
No, it does not make any difference because these incisions, you can extend it a little bit and you can go up and down. There is no problem.
Okay.
I want to add.
Thanks.
I want to add something.
Yeah, please.
See, the thing is, they are very good because it's on the Langer's line, which are the connective tissue deposition. But the thing is, in spine surgery, you should always be ready for a revision, and in obviously above level, down levels. So if you have to re-explore and everything, the vertical incisions are much better, and they help you to go up and down and revise it also in the long term. So I I think the vertical incisions make more sense if you think that patient will have to have a problem later on, you may require a fusion, then it's a better to have a vertical incision than a horizontal incision. Thank you.
Sure.
Very good point, Sudhir. Very good point.
Thanks, Sudhir.